Hello, and thank you for joining us today. My name is Peter Dye with the California Primary Care Association. On behalf of CPCA, I would like to welcome you to this webcast on patient-centered medical home annual reporting. The purpose of this webcast is to provide health centers with a deeper understanding of the NCQA PCMH annual reporting process, while sharing best practices and learnings from a practice's recent experience completing annual reporting for PCMH as part of a multi-site organization. I would now like to introduce Valerie Padilla, Quality Improvement Coordinator at Open Door Community Health Centers. Valerie, the floor is yours.
Hello, everyone. Thank you for joining me today. My name is Valerie Padilla. I'm a Quality Improvement Manager for Open Door Community Health Centers. In my role, I support 5 of our 10 primary care locations, and I work with all of our teams to support their population health and quality improvement efforts at their sites. I am also Open Door's PCMH champion and manage our application processes and annual submissions for annual reporting. A little bit of information about Open Door. We are a federally qualified health clinic located in Humboldt and Del Norte counties. These counties are California's 2 farthest northwest coastal counties, and we serve patients over 120 miles. We provide medical, behavioral health, SUD, HIV, and dental services. We have 10 primary care locations, 3 dental locations, 1 mobile medical, and 2 dental vans. In 2020, Open Door supported approximately 59,000 unique patients and over 280,000 visits. We are PCMH recognized for 8 out of our 10 primary care locations, and we have first received recognition in 2015. I wanted to start with the evolution of the PCMH process for those who might be coming into it now in 2017, 2020, 2021, or who have been here for a while and might understand how it went from the beginning to where we are now, as far as how you apply and receive PCMH recognition through the NCQA. In 2014, the process was incredibly time-consuming. It was heavily driven off of a paper process for submission. This created a lot of duplicative work for a multi-site organization like us. We had to replicate the same documents for every single site that we submitted for, which at the time was 5. This took countless hours to submit. It wasn't very streamlined or organization friendly at that point in time. In 2017, the program had a significant overhaul. The NCQA streamlined the application process and transitioned to a 3-part recognition process: commit, which is the beginning portion, your readiness assessment, preparing for your application; transform, which refers to your actual application and review process; and succeed, which refers to your annual reporting and continuation process after you've been accredited and recognized. They also launched the QPass platform to support application and submission. They implemented a virtual review process, which resulted in significant reduction of evidence to be uploaded, and also allowed you the opportunity to have a reviewer that you met with multiple times to go over all elements that you were submitting. Whereas in 2014, you submitted your paper document and had very limited ability to communicate with your reviewer and make a case or explain anything that might have needed additional explanation that wasn't explicitly clear in the paper documentation that you uploaded. They also significantly simplified the process for multi-site submissions, which allowed us as a multi-site organization to have a large number of criteria carry over from site to site, and that would mean that those criteria were shared. And then there was a subset of criteria that were site-specific that required us to submit specific information for each of our locations we were applying for. They also transitioned to an annual reporting period instead of a 3-year recognition program, and then in which you had to reapply. Now they have once you finish your transform period, you successfully are recognized and accredited, then you move into the succeed phase, which is your annual reporting phase, which allows you to report every year on the activities that you've maintained towards your PCMH. And in 2021, they've transitioned to a single sign-on to access all NCQA platforms with a single login. This makes remembering all of your logins and locating everything much simpler, and they continue to make improvements to QPass to make it more user-friendly. Annual reporting is known as the succeed phase within the PCMH recognition process, as I've mentioned, and the NCQA defines this as each year the practice demonstrates to NCQA that its ongoing activities are consistent with the PCMH model and recognition standards. The annual submission includes attesting to certain policies and procedures and submitting required evidence or data. So we're going to dive into the details of annual reporting and what you're required to report. So you're required to submit information, data, and evidence for selected key criteria that support each concept listed here below in the PCMH program. How you're required to report data varies from criteria to criteria. Some of them are questions. You simply answer a question. Do you do this? And then you have to say how you do it. And then others, you're attesting to doing this activity. Others require that you submit data or a report to demonstrate what they're asking. Other criteria are informational, and the NCQA is only trying to gather information on these, and your responses in no way affect your recognition status. So these categories are probably very familiar for you if you're already in the annual reporting phase. These are the core categories that you moved through in your initial application process. So team-based care and practice organization. In this category, you'll be required to show something like pre-visit planning. How does this happen at your organization? It also might require that you monitor and attest that your teams are huddling every single morning. Knowing and managing your patients. In this category, an example of something that you might have to show is, or attest to, is that you are doing proactive reminders and the frequency at which you're doing these proactive reminders to patients, that you're screening your patients for depression using a standardized tool. In this category, at least for this year, for 2021, you will have to submit data around those depression screening rates. Patient-centered access and continuity. You will monitor your access and preferences. They'll ask you what methods are used to assess access. This can be something like same-day appointment availability, routine appointment access, electronic patient requests, advice during and after hours. Telehealth access is being assessed this year. This is an informational only category. It in no way affects your recognition. Care management and support. In this category, you'll talk about, or you'll have to attest and answer questions to how you identify patients for care management. We, as an organization, identify patients with a behavioral health condition. We've selected depression if they've had a PHQ score greater than 15. Patients with high costs or utilization. This is our patients who are in current and ongoing hepatitis C care. And then poorly controlled or complex conditions, and we've selected patients with diabetes who have a A1C greater than 9. Also in this category, you'll have to attest that your providers and your care teams are creating care plans for patients for these conditions that you've selected, and that these care plans are printed or made available to the patient in an electronic format. Care coordination and care transitions. In this section, you will need to demonstrate a documented process for follow-ups on labs and imaging, flagging abnormal results, notifying patients and families of results. There's a variety of criteria in here that you'll have to attest to or answer questions around. Performance measurement and quality improvement. Measuring performance in clinical quality measures is something that you will have to demonstrate within this category. You'll have to show how you manage care coordination, healthcare costs, and what goals and actions your organization has in place to improve in these 3 areas. In this section, it's highly encouraged that you use the QI worksheet that the NCQA provides. I am going to show you the sample that they give you to give you an idea of what this document looks like. It is incredibly helpful. It lays it out for you very clearly on what is required. This is their tip sheet that is included. You have the various categories that you need to submit, gives you what is required for each component within the worksheet and examples of what is not accepted. They also have a completed examples sheet that gives you specific examples of measures that other organizations have used or recommendations, and it walks you through all of these different elements and what would be accepted. This is a really, really helpful template. And then they break it out by the different topics that you'll need to submit for. As a multi-site organization, you can use one workbook for every single site. In many situations, the same measures will be applicable across multiple locations. And in others, you may have to select a different measure for each site, but this workbook allows you to consolidate all of your submission in one workbook. Also within here is really helpful links to this FAQ directory, which has questions and examples that might not be addressed in this tip sheet that they encourage you to look at that are updated frequently and are very helpful. And the estimated time to prepare your submission, the NCQA estimates about 15 to 40 hours of work per year. This will definitely vary depending upon the size of your organization. I also think that for your very first year that you're moving through annual reporting, this may take longer. It definitely took me a little longer in our first year to figure out exactly what was needed, to work with the different subject matter experts at our organization to create the reports that we needed for monitoring. But moving forward, I think the 15 to 40 hours of work per year is a pretty good estimate. And then to submit on QPAS, when you're actually ready to move forward with your submission, the time will be around 1 to 2 hours. Again, if you are a very large multi-site organization, this may require more time, but the process online is fairly straightforward since you're primarily answering questions and attesting. There's not a whole lot of data entry required during your application. The most amount of time will be in the preparation as you complete your monitoring throughout the year and your QI worksheet, which I just shared. So as you're preparing for annual reporting, one thing to really think about is the role of the care team in your patient-centered work, especially in the context of PCMH and your accreditation and renewal process. The patient obviously is at the center of the care team, but the care team has some very essential PCMH functions that they must maintain in order to sustain PCMH efforts day in and day out. Things that are pivotal functions of the care team are things like pre-visit planning. We determine teams are completing their pre-visit planning and prepping for visits as we expect by reviewing schedules. We pick a various week or two throughout the year. We go in and we check that every single provider's MA and care team is doing some sort of pre-visit planning on those random weeks. And then we feed information back to the care teams when we see that there are some deficits that need to be, that have been identified and gaps that need to be closed. We also want to make sure that our teams are huddling. It's a core function of a PCMH, is making sure that you're having a team meeting to discuss what's happening. These happen at our sites in the format of a daily team meeting. Most huddle every single morning. Some huddle in the morning and after lunch, but they huddle at least once a day. Several of our locations host what they call mega huddles. So it's not just the clinical care team in the back office, it's the entire site, referrals, call center, front desk staff. Everyone comes together and they have various updates that are made during that mega huddle. Coordination of care across the organization and with community partners and specialists is a key function of the care team, making sure that those patients are connected to member services team if they need help with coverage or navigating any programs or services they might be eligible for, case management if there's a need identified that they need some support around. And then within community partners and specialists, working closely with our referrals teams to make sure that the patient referral process is followed through as we expect. Population health management is another core aspect of the care team that is supported because of all of the other work that the care team, the actual physical patient care team, manages. We support a lot of the population health management work through our population health specialists. They function as what we call an extension of the care team. It's a centralized team that supports outreach for chronic conditions and preventative care. They support abnormal tracking and follow-up on all of our preventative cancer screenings like mammograms, PAPs, colonoscopies, FIT testing. But the patient care team is leveraged and asked to support some of these efforts because they typically have a very strong relationship with their patient population. So we do still enlist their help and have the expectation that they are monitoring for population health needs. And another essential function of the care team is quality improvement team meetings. These take place at every single one of our sites, and this multidisciplinary team works together on a variety of process improvement projects that are both clinical and operational. A population health team member like myself, I have a counterpart who supports a different region of the organization. We are QI managers. We support those team meetings. Our chief quality improvement officer will attend those meetings. And so they have some kind of additional support and guidance during those QI team meetings. So now we're going to dive into what the reporting requirements are from year to year. So there's lots of areas where you need to attest or they ask you a question and you need to respond about, do you do these things? And if you're attesting to them, you definitely need to make sure that you're actually doing these things. So your time frame for reporting for PCMH and per the NCQA is defined by the organization. So you can look at any time period within your reporting year. You can look at a quarter, you can look at 2 quarters, you can look at the whole 12-month period, but you as the organization define that time period. It's important that you monitor for activities year-round, especially those that you're attesting to, like I mentioned. Another piece of advice is to leverage your EHR or population health management tool that you use, like Eye2Eye or Eagle Dream, whatever your organization is working with. You leverage those tools to be able to monitor for these things in a more systematic way. So these are some examples of some things that you should consider to monitor for and that you might need to report out on. So depression screening, they want to know which tool you've used and your screening rates. We use our UDS reports for this. We are able to generate that data by site. For care management, we have worked closely with our business intelligence team to create a report on our BI server that we use for this. We've identified 3 populations that I touched on before: patients who have diabetes with an A1C greater than 9, patients who've completed a PHQ and their score is greater than 15, or patients who are currently undergoing treatment for hepatitis C. You are able to access the database, enter a time period in which you'd like to review, and it will generate a list of patients who meet those criteria. And then you can go in and you can review that these patients had a care plan, that their care plan was printed, or that they're an active MyChart, which is our electronic patient portal. They're an active MyChart user, so they can access their care plan online. Referral or lab or imaging tracking, you need to show one of the 3 of these. You don't have to demonstrate or report out on all three. You select which you would like to do. For us as an organization, we decided to focus on referral tracking. So I worked very closely with our Director of Clinical Support Services and our Business Intelligence team to develop, actually to refine an existing report and modify it in a way that would meet the need for our quality reporting that was needed for PCMH. The quality measures, there's 4 categories that are listed, and you have to select 3 measures across 3 categories of the 4 listed below. So you can't pick 3 immunization measures. You have to pick 1 measure within at least 3 categories. So within these categories, this is where you would go ahead and you would use the QI worksheet that I just showed. You would go ahead and select your measures and complete the worksheet for each site that you are submitting for. So some examples of what we used for our submission last year, and we'll likely use some of the same measures this year. For immunization, we looked at childhood immunization rates, this being that recommended immunizations are completed for children by their 2nd birthday. For other preventative care, we used, for the majority of our sites, we used the infant well child measure. So this is patients have 6 well child visits in their first 15 months of life. One of our sites is very small and has almost no pediatric patients. So we had to select a different measure for them. We selected cervical cancer screening. We did not elect to use chronic and acute care. We chose our 3rd category and measure to be for behavioral health. And in here, we talked about depression screening and our follow-up process that was implemented for patients who had a PHQ greater than 15. For resource stewardship, they're looking for some kind of care coordination measure. And we selected closing the referral loop. So not only were we able to utilize the data that we generated for the referral tracking piece, but we were also able to use that same information for our QI measure. So we were able to kill 2 birds with 1 stone in that and not create 2 separate reports that needed to be completed. For patient experience, there's a variety of things that you can do in this topic. We selected communication. We have been consistently monitoring the helpfulness and courtesy of staff answering the phone. So we talked about the efforts that have been put forward to increase our patient experience in that specific category. And we monitor our patient experience results and have a work group in place that has been affecting change with our front desk and call center teams related to that measure. Okay, so next we're going to talk about leveraging your EHR. We use Epic. We are part of Ochen's network, so they are our EMR vendor. And I highly recommend leveraging and using any and all reporting tools that are embedded in your EHR or your population health management tool like Eye2Eye or Eagle Dream to create custom reports for monitoring or to use existing reports that are helpful for you. So this is an example of a custom provider dashboard that we worked with Ochen to put together, and we're continuing to refine, but this is something that we've been able to use to leverage our EHR to review how providers are doing for specific measures and identify areas where they might need some improvement. This is available for the provider to look at for themselves. You can look at the site level and the organization level. Another way that we leveraged our EHR is collaborating with our business intelligence team to create custom reports that can't be generated from within your system, but rather pulling out information from your EHR into a program like Tableau or whatever platform your organization uses. So below, what you see is a screenshot of our referral tracking report that was modified from an existing report to meet the needs for our PCMH submission. So here you're able to see, for the purposes of referral tracking, we're able to look at a specific time period of the referrals that were generated, and of those patients who engaged in care, how many of those referrals were closed? How many referrals did we successfully close the referral loop on and receive that report? So this is some information that we were able to use to complete our QI tracking workbook and create the numerator and denominator required submissions within QPAS for that specific criteria. So some best practices, we've created this list of best practices from all of the lessons learned that we've identified as we moved through our first year of annual reporting. So first and foremost, it's very important you have a PCMH champion. For our organization, that's me. I started being a part of the PCMH application process and championing this work way back in 2015. Since things have changed and the organization has shifted, the number of sites that we've had come on board has grown significantly. So while I am the PCMH champion, we leverage the other team members on our QI and pop health teams to support this work across your organization. And it's really important that these folks help carry that PCMH torch so that you're able to ground your work using PCMH as a guiding principle, and that this is done year round. Our QI team does a great job of pushing patient-centeredness in every single meeting that we participate in any project that we're involved in or not involved in, but hear about, and that might not be taking the most patient-centered approach, that you just constantly are kind of the guiding light for teams to remember to keep the patient at the center of everything that you do. I highly recommend that you create an annual reporting tracking workbook, and I will share what we've created. And it is probably far from perfect, but it's definitely doing the trick for us. I created something similar for our initial application process. Obviously, it was much larger because the categories of the criteria were far more extensive than what's required for annual reporting. But I have a Excel tracking sheet that looks exactly like this. And every year I go through and I update the requirements. So this is the category, and then this is the specific topic in which you need to report on. I have a status column that you can update with a color, and when it's complete, it changes. It has conditional formatting built in to identify where you're at in the process, so that it allows for simpler tracking and filtering. I've also indicated if it's a shared or if it's a site-specific requirement. That makes it easier for tracking when we are submitting for 8 sites, which we need specific data on, and which we can submit data on an organization level or answer a question on an organizational level. I've included the reporting requirement, if this is required, if this is optional or informational. And then the task, what you actually need to do in QPAS. Is this a question? Are you attesting to something? Are you submitting a QI worksheet or some other kind of report? And the description of the requirement is verbatim exactly what is from the annual reporting standards and guidelines. And then what's in green is our organization's response. So a sample of a question is, how does your practice anticipate and plan for upcoming patient visits? And you select all that apply. And so I've indicated these so that I can have this workbook up as I'm going into QPAS and updating the questionnaire for all of our sites. I can quickly look over, see what our response is, and select the correct answers in QPAS. I've also mapped, again, this is directly from the manual, so I'm not doing any extra work. I'm just taking what they have and making it in a more usable way. I've mapped to which PCMH criteria this aligns with, because you'll notice the topic for annual reporting is ARTC1, so annual reporting, team-based care and practice organization, patient care meetings, but that is a different PCMH criteria if you were looking at the complete and full standards and requirements that you would use for your initial application. So I've mapped which that is here, and almost all of them are core criteria. You very seldom have to report out on the optional criteria from your initial application. And then I have a column here that is solely for our internal purposes and notes how we monitor for this, what things we might look for, if there's a report that we're going to use, which one, where it's located. So say I win the lottery and someone takes over, they're able to jump in and see where we're at with all of these things and where I was planning to get this information. I track a variety of other things in this workbook. You can track your fees, how much it's going to cost for you to apply for and receive your annual renewal. I have a gigantic list of all of our providers. I have a variety of things that I show that I do some monitoring on. So I've started for this year going through and doing our chart scrub, pre-visit planning audit. So you can use this workbook for a variety of things, and I've found it most helpful that all of this information lives in one place as opposed to having multiple workbooks that you're tracking things in. Another really important component and best practice is communication. You need to communicate with your care teams early and often about deficits. It's very difficult to affect change if you're not communicating with your teams consistently. If you go in to do your annual reporting and it's your reporting period, you have to submit in, say, September, and you start going in and you're auditing in August, and you realize that no pre-visit planning has happened all year long, and you're about to go in and attest and say that yes, your teams are doing these things, and you're scrambling to communicate with your care teams about this work that needs to be done. That's very difficult to do, and it's to no fault of your care teams if you're not communicating early and often enough with them. We communicate in a variety of ways. We communicate in a weekly huddle news bulletin where we share a variety of different information, and it goes out organization wide. We have our QIT meetings, which I've talked about, where we bring things forward. We have those at the site level, and then we also have a population health lead meeting. So we have identified staff at every single location that come together once a month to talk about population health work and efforts, outreach, quality measures. We share a lot of information there. We make sure that information is shared at provider meetings, RN meetings, and that those leaders take that information back to their teams. As you're doing all of this monitoring and you're reviewing things throughout the year, things will come up that you realize need to be revised or changed in your workflows, your policies, your standard operating procedures. Just because you create those one time for your initial application or years ago, that it doesn't mean that they are set in stone. Workflows and processes change, and it's important that you review and revise those as needed. So as an FQHC, we have HRSA cover our renewal fees. And if you're an FQHC and planning to do this, I highly recommend that you submit your notice of intent, your NOI, to HRSA 6 months prior to the renewal deadline to give yourself plenty of time. This may be way too much time, but in my opinion, based on the experience that we had last year, I would much rather have it done as far in advance as possible, knowing that you're going to renew at some point during the year, than waiting until the very end. We did not submit last year with enough time. I'm not the identified staff at our organization to submit to HRSA's EHB. You need to have, at our organization, it's our chief administrative officer. She had to submit our notice of intent, and the EHB, the electronic handbook, is not very user-friendly. It was very difficult to navigate and figure out where this goes, and then who receives the notification from when the NOI is reviewed and accepted. So we got in a position where we had completed all of our requirements in QPAS. We were ready to click the button to request our virtual review with our reviewer, and we found out that you need the sponsor code at that point in time to be able to move forward. You have to pay before you can submit for your renewal. So unlike with your initial application, you can't do anything in QPAS until you have that sponsor code. So that's step one for your sponsor code, but it works backwards for annual reporting. You can update and enter information in QPAS as early as you want, but so it's not driven off of your payment first. So I highly recommend that you work with your team to identify who your HRSA liaison is at your organization and get your NOI submitted to cover fees. NCQA recommends, and I agree, to at least start preparation 6 months in advance to ensure that you're going to be able to meet timelines, to assess your readiness, to make sure that you've done some monitoring, that you can confidently attest and answer questions, that you are still maintaining these activities when you go into QPAS and you're saying yes and submitting that renewal form. It's also really important to understand your EHR's pre-validation criteria. When you do your initial submission and application in the transforming phase, you, depending upon your EHR, you are pre-validated for a variety of criteria. It's important to understand what it is that you're pre-validated for in case there is a situation where during an annual reporting period, you are required to report out on something that you just automatically received credit for during your initial application. I haven't seen this yet. This is only year 2 for us, but I am anticipating that that may come up, and I am going to make sure that our team is prepared to report out on anything that we're saying or we've received credit for our EHR automatically doing, and making sure that we're following the appropriate workflows to demonstrate that that in fact is happening at our organization if required to. And I can't stress this enough, to identify and leverage your subject matter experts for areas that your PCMH champion doesn't actually do the work in. Like I said before, I worked really closely with our Director of Clinical Support Services and our BI team related to the referral tracking reporting that was needed. I am in no way our referral expert, so I leaned really heavily on our leader in that area and basically told her what I needed from her. I shared it as early as possible, and we're doing the same thing this year. We'll share what we need, and she will essentially go in and make sure that everything that we need for PCMH is taken care of. So you're able to really lean on those folks that are the experts at your organization in those areas that you're required to report on. And next steps for us at Open Door, we plan to develop a standard operating procedure for PCMH annual submission. Since this is our second year, we want to go ahead and commit to paper all of the things that you need to do in order to prepare for annual submission. We hope to continue to refine reports used annually for annual reporting and monitoring throughout the year. That is something that we'll be identifying now as we prepare for submission in September, as we're going in and using the reports. If there's any breaks or fixes that are needed, we'll work with our BI team, or we'll refine the reports that we've personally created in our EHR. We will be applying and achieve recognition for our 9th clinic in 2021. And we will also assess the readiness to pursue distinction in behavioral health integration. And I just want to thank you all so much. Here's my contact information. Please feel free to reach out if there are any questions.